Good afternoon.
Good afternoon.
So my name is Voelzke. I'm the son-in-law of Catherine Hanslick. And then my father-in-law, Joe Hanslick. So little story how I ended up here. I ended up here because of my wife, their daughter. I'm originally from the foreign country of Texas. And I met their daughter at Wake Forest and took a job in Tennessee for a period of time, and then after being there for 3 years, we wanted to get closer to family, and there were a couple other reasons as well. Our middle son needed some additional help with some issues that he had, and we just didn't really find the help that we needed in Tennessee, so we moved to Richmond. We've been here now for 3.5 years, and anyway, we're happy to be here. In terms of the CLL, a couple things I wanted to comment on before I started. The CLL question. There's some new drugs out. CLL is one of the exciting fields of advancement for new drugs. And so if you haven't already been told about some of the new drugs, I don't know your situation, but there is a lot of new promise for CLL. And then the other thing I took from listening to you guys is that sometimes we physicians don't listen very well, it sounds like. And I'll try my best to leave plenty of time so I can listen and answer questions. Okay. So my talk is on lung cancer. I know that a lot of you guys in here don't have lung cancer. In fact, hardly any of you guys have lung cancer or are connected to that. A lot of these folks here, it sounds like with COPD, pulmonary fibrosis, like my mother-in-law. I'm going to try to not bore you to death, okay? And I'll try to make it interesting, and like I said, keep to the time at the end so you can ask questions. Okay. Okay, so in the United States, lung cancer, I'm going to start off sort of just giving some basics so that the rest of this hopefully will be more interesting. But I'm just going to give some basics first. Lung cancer is number 2 in terms of incidence. For men, it's behind prostate cancer. For women, it's behind breast cancer. But unfortunately, it's number 1 in terms of cancer-related deaths. So we have a lot of progress that we need to make in lung cancer. Also, just for discussion, which we'll get to later about the new treatments, I think it makes sense to spend a few minutes going over the classification of lung cancer and then the staging of lung cancer. Lung cancer is divided into 2 big groups, small cell, and then they were very creative back in the day. They named everything else non-small cell. At one point, which wasn't that long ago, probably 15 years ago, non-small cell, there are subtypes, but it really didn't matter which subtype you had because they were all treated in a very similar fashion. That has changed, and that has changed because of new advancements in lung cancer, but also just a better understanding of the human body. I was at a meeting in January of last year in which they were talking about the sequencing of the genome. And when it first happened, it cost, millions of dollars. And it took like over a year for them to sequence it. And now, they can do it for thousands of dollars and do it in, I think that they told me a day. It's crazy how much they can, and I may have that a little bit off, it was pretty remarkable. It was like from forever to now, maybe it was a day or a week. I could have it off. The point of it is that we've made a huge advancement in terms of of understanding how genes work, which genes are important, which genes are involved in cancer, how can we do things to make bigger impacts in the treatment of cancer. I'll be the first to tell you we're not there yet. We're not there yet. We got a long way to go, but we're getting really close to a lot of progress. So the exciting thing is now it's not just small cell and everything else. We're actually talking about small cell, non-small cell, but then within the non-small cell umbrella, there is subtypes of adenocarcinoma, depending on if you have a certain mutation, which we'll talk about. At one point, squamous cell was the largest of the lung cancer in terms of the piece of the, in terms of most common of the lung cancer subtypes. Now it's adenocarcinoma. Okay, so this is a somewhat boring slide, so I apologize. But I think it's helpful if you ever go see a physician, hopefully it won't for you, but maybe for a family member or a friend, and they talk about staging, I think it's kind of helpful to know what it means. Staging for lung cancer is similar to staging for a lot of other cancers. There's three important parts to it. Number one is the T, or the tumor size. So we actually subdivide this as the T-N-M staging system, where T is for tumor size. For some GI cancers, it may be tumor depth. N, the second part, is lymph nodes. Are there lymph nodes involved? And then the third part, the M, is metastasis, which we'll get to that in a second. That means distant spread. So by definition, for the most part, if something has spread, it's stage 4 because it has metastasis. It's spread. Stage 1 through 3 has to do with the tumor size, or in the case of GI cancers, tumor depth, and then the N stands for lymph node involvement. So for lung cancer, it's subdivided into T1, any cancer less than 3 centimeters, T2, 3 to 7 centimeters, T3 greater than 7, and T4 invasion to other structures. And then, as this graph shows you, if the lymph nodes are close to the cancer, it's T1. If it starts to spread, N1, back up. Sorry, if it's N1, these are the lymph nodes here that are close to the cancer on the same side. If it gets to the center of the chest, it's N2. And if the lymph nodes cross midline to get to the other side, it's N3. And then, of course, M, as in Mary, means metastasis, means it's spread. So, isn't this exciting? I can.
Yes, it is. Yes, it is.
So, what happens is, it's like the days of the slide rule. You basically take all that other stuff, sort of combine it, then you get a stage. So if there's a tumor that's smaller, but it's a T2, and there's no lymph nodes, it's a stage 1B. If it's a T3, but it has N2 lymph nodes, it's a stage 3A, and so forth. So that's how that works. I always like to start off when I see a new patient to make sure we go over what do you have, and what stage is it, and then what does this mean to you? I mean, how does this affect your prognosis? And that's the real nitty-gritty stuff you want to know. What do I have? What stage is it? What can we do about it? So I think it's important when we're talking about the treatments for the rest of the slides to make sure we go over kind of the landscape of lung cancer. Now, the majority of this talk is going to be about non-small cell lung cancer. But there's a group of small cell, and the small cell staging is a little bit different. You can do the T-N-M staging, but for practical reasons, lung cancer that's small cell is subdivided into limited stage and extensive stage. Now, all that means is that limited stage, they can put a reasonable radiation field where the tumor is. An extensive stage, it's outside of that. And the reason why it's staged that way is because it helps to dictate the type of treatment. If a gentleman or a woman has small cell, it's very important to figure out if we can get our radiation colleagues to do a reasonable field to incorporate the cancer. And if so, then that's a limited stage and it's treated with both chemotherapy and radiation. So that's how small cell works. And just what I just said. Okay, now this is depressing, and I'm sorry. but it is what it is. I always, when I see patients, I may talk about prognosis, but I've got a handful of patients, and every physician does, who just don't follow the script, which is awesome. Because a patient who I frequently talk about, because I've given a couple pancreatic cancer lectures before, is a patient of mine who, when I first moved here to Richmond from Tennessee back in 2011, she was diagnosed with pancreatic cancer that had spread to her liver. Now, lung cancer, it's depressing, but pancreatic cancer, unfortunately, is even more depressing. She was treated on a clinical trial that we offered, and she's alive today with no evidence of disease. So that's 3.5 years ago. I saw her last week. So the point that I'm making is that everyone's life story has beginning chapters and end chapters. I don't know how many more chapters are left in Mr. Jones or Mrs. Smith who comes in. And the beautiful thing is, no one's going to follow the same script. So while it's helpful to know some statistics, some of which can be really depressing, it's also important to know that that not necessarily is going to be your path. You know, there's no reason to assume that because the statistics shows this is how the majority of people do. There's always outliers. So I always try to bring that up because I think sometimes inadvertently, or maybe for some physicians, maybe, I don't know, but it comes across like we know more than we do. You know, we don't know exactly how Mr. Jones or Mrs. Smith's going to do. I think it's helpful to tell them what to expect so they're not blindsided if things don't go according, go perfectly. But on the other hand, to mention and to point out that there are outliers so that you don't squash that very important hope. Okay, now to the depressing slide. The top part of this slide is data from a lung cancer staging project where they went back into basic tumor registries and they found from stage 1 through stage 4 what the average survival was in 5-year survival. Now that MST, this right here is median survival time in months. So a stage 1A, median survival was 5 years, was 60 months. For a stage 2B, it's 18 months. And then unfortunately for stage 4 or metastatic lung cancer, it's 6 months, with 2% alive in 5 years. Now, this data, a lot of this data you had to compile over years before we've made some of the advancements in treatment of cancer. But our advancements, as I said a few minutes ago, aren't as great as I would like them to be, so there's still a long way to go, and these numbers aren't that far off. So what have we done? Well, actually, before I start that, let me sort of explain how the rest of this talk's going to be. I'm going to talk about non-small cell cancer, non-small cell lung cancer, because that's the majority of the lung cancer. I'm not going to talk about small cell, and I'm going to talk about stage 4 non-small cell lung cancer specifically. Okay, so the rest of these slides will be on stage 4, the metastatic non-small cell lung cancer. So what have we done to treat stage 4 lung cancer? So the first plan was give chemo. That's what the original plans were.